Well, hello ladies and gentlemen, and welcome to Hamburg. You join me this week at the University Clinic Hamburg Eppendorf, which is a very large academic university hospital here in Hamburg. But I'm here in particular to visit the Martini Clinic, a unique prostate cancer centre here on the site of the main hospital campus, which I'm sure is known to many of you. But for those of you who are not familiar with the Martini Clinic, I hope over the next few minutes to bring you a real snapshot of what makes this place unique. The Martini Clinic is the world's largest radical prostatectomy centre, performing about 2,500 prostatectomies per year in their unique standalone building here on the hospital site. I'll be spending some time with Dr. Markus Graefen, who's the chief of the department here, and his team, spending some time in the operating room and hearing about their research, which I hope you enjoy. I'm certainly looking forward to it. So here at the Martini Clinic with Dr. Markus Graefen, the chief. Nice, thank you for welcoming me back to your fantastic clinic, Markus.
I may say that we're always happy. We're really excited knowing that you're coming by, like your European trip, and yeah, we are all very, very happy to have you back here.
I think it's my third time to come and visit the Martini Clinic.
I think so, yeah. Every time it's getting better. So.
For me too. And look, I've had a great day already today in the operating room with Alex Haese, watching some Neurosafe, the frozen section technique, which is still fantastic, I must say. We're very envious. We haven't quite got to the stage of doing that in our centre yet, but it's awesome to see it done at the scale you've set up here. So congratulations on that.
Thank you. Thank you.
And also, you're expanding. That's the other very exciting thing I want to talk to you about. But before I get to that, for listeners and viewers out there who may not know the Martini Clinic, they might know the name, but they might know how it all got set up. And that's a story I really enjoy listening to you talk about. I've heard you speak about it a few times, just explaining what is the Martini Clinic, where did it come from, about yourself and Hartwig. So can you take us back a few years and tell us how did we get to today before we ask you about where you're going in the future?
Okay, yeah, I must say I really love to talk about the Martini Clinic as well and about this history, because I must say I still like it very much, how the things develop. So the idea of the Martini Clinic was that we saw that with specialization, with going more into depth about clinical issues, research issues, that you can really get forward better than in a typical urology department that we have typically in Germany here. And so we came up with the idea to the directors of the university and said, we still have this, or we already have this let's say, big spot of prostate cancer. Hartwig was what we always called the Pope of prostate cancer those days in Germany, and he was one of the reasons why I actually came to Hamburg. Yeah. And we had so many patients, but didn't have time to really take care of them because we did take care of everything else as well. And we approached the directors, and they said, okay, why don't we try it out? And that's how it started. And this is 17 years ago now. This is this building here. It was kind of a leftover building that we renovated, just a couple of rooms, because we wanted to see how it is, how the patients accept that and the referring urologists accept that. But we were really overwhelmed about the, I must say, success of the clinic. And the strengths, I think the typical things is the complete specialization. And you have met a couple of people here who have then their sub-specialization in prostate cancer, like Derja, like Tobias Maurer, like Alex Haese, Thomas Stoiber, Gunhild von Amsberg, medical oncologists. So we try to be in every part of prostate cancer. We try to have experts and keep them here. And so we have this database where we track the patients. Actually, already we started with that before Martini Clinic. Yeah. In 1992, Hartwig had the idea of creating a database, and I took over and did the work on that. And I think the faculty system as well. This, I think, the third very important issue. Germany typically is very hierarchical. And
it's more like a pyramid.
Absolutely, yeah. And the boss always, he knows what should be done, and typically he knows better than everyone else, and so forth. And Hartwig was always someone who was questioning that. He always wanted to have evidence. He was not like he's perfect anyhow. So this is so many years ago, 17 years since we founded the Martini Clinic, and now we are, I would say, established as a prostate cancer center. We are by far the largest surgical center worldwide, I may say, but this is not the end of the story.
Yes, and it's if we stop there for a moment and think, what you've just said, because you just said it out, but it's a huge thing to say that we are the world's highest by volume radical prostatectomy centre. And it's still a mixture of open surgery, Markus, and minimally invasive surgery, because the heritage from Hartwig and yourself was very high quality open radical prostatectomy. But a lot of the young people out there listening to these podcasts will just presume everything is robotic. But in 2022 here in this uber high quality radical prostatectomy centre, that's not the case. Robot doesn't equals quality in a place like this.
Yeah, I must
or
say,
necessarily superior quality, I'll say.
superior quality, and certainly costs are an issue in the German health system. And even though we can certainly talk about the cost of medication and so forth, but as well, this is something that patients or the health system considers. And the other important issue is certainly that we do a lot of tracking of our data. And when we go to our data with the high experience in open surgery, and open surgery has developed as well in the last years. It's not only that the robot has developed, we're doing the open surgery now with a minimal blood loss today, transfusion rates of below 1%, discharge rates are just the same. So, and therefore some patients, I would say maybe it's kind of a German thing, some like the German handcraftsman a bit more, and handcraftship. The referring urologists sometimes still like open surgery more because they know the results and the results are good, never change a winning team, kind of that attitude. Yeah. But certainly, as we see all over the world, the robot is taking over. So we are having 4 robots now. We're certainly looking for a new system. The Medtronic system is up there. We didn't use it yet, but we want to do that. We want to compare it with intuitive systems. So we want to do clinical research in that field as well. But yes, a couple of patients we are doing open.
So, and that takes us to where we are today in this building here in the middle of the main campus of the hospital in Hamburg. 5 operating rooms, all doing radical prostatectomy. I still think that's kind of amazing for someone like me who loves this operation and fully agrees with you that high volume will drive quality. To be walking around here and it's prostatectomy in every single operating room. But even with that, that's not enough to cope with your volume. So this is 2,500 radical prostatectomies a year in this building. But I see building a huge new Martini Clinic right next door to us.
Yeah, I must say we are very excited about this in the way that it offers us more opportunities than we have now compared to the situation here. This was it's a nice building, but it was not made for serving prostate cancer patients. And so we will have there an own MRI. And now the patients have to walk to the MRI department. We'll have our own urologist here. So making it more, let's say, convenient for the patients, having a closer contact with the imaging guys. Just as one example, we have our own chemotherapy outpatient clinic here with Gunhild von Amsberg. She's a medical oncologist working for us for 2 years now, since 2 years now. So we would like to, the whole idea is not to be let's say, a factory for radical prostatectomy, but rather to be an integrated practice unit. And with the new building, we can better serve that idea of covering the whole prostate cancer treatment spectrum compared to this building. And
I hear that nice. A lot of the design elements in the building is about, making sure the patient has a good journey, very nice open spaces and light and all that sort of thing, that in any sort of modern cancer practice is very, very important. Not just the quality of the care, but the environment is important.
Absolutely. I think patients, I think it's a good attitude. They deserve being treated in a nice surrounding. I must say I was so impressed when I went to Peter Meg. That was the best I've ever seen in my life without saying sweet words, but I was so impressed about the architecture and the idea behind that. I remember that you told me that a patient created as an architect the whole, and he was thinking how the patients are going inside and that they don't get in touch with other patients too much. And we had kind of these ideas as well. We involved very much the whole team, the nurses, the administrative staff and so forth to think about what are the demands and the needs for the patient, how is it nice for him, and as well, how is it, I would say, streamlined for the personnel as well, for the staff. It's not only about the patient, but you would like to treat your staff nice as well, because you want to keep them here in the center and offer them a nice, let's say, professional surrounding. And I think we will achieve that.
And for those people watching on YouTube, we're sharing some nice pictures that your team have given us about what the new building will look like. But I can see there's a huge building already gone up. So when are you hoping to move in? What's the plan?
I hope when you come by the fourth time, which is in a year from now.
Yes, a year from now, fantastic.
A year from now, yeah. It sounds a bit, let's say, another year we have to wait, but certainly we are facing the reality with the bad things that's going on in the world, and so we have some delay in the building, but not too much. And in a year from now, we're probably in there.
And how many operating theatres, just to make me even more?
Eight
operating theatres,
yes.
All doing radical prostatectomy all day long.
Yes, sure.
Yeah.
And certainly radio-guided surgery. You will have the chance tomorrow to see Tobias Maurer. I think that is an area we don't want to discuss the role of metastasis-directed therapy, but I think this is something we certainly will have the chance to do brachytherapies there as well, focal therapy, which we have a program there as well. We're offering HIFU and 2-cut, and so it's not purely radical prostatectomy, but I may say that many patients who actively have chosen or have made their treatment decision then look for experience center and very often end up here. So I'm 100% sure that the mainstay of our treatment will be in the future still radical prostatectomy, yes.
And I must say, I know I keep going back to the radical prostatectomy because I'm still just so enthralled by how you can create such a high volume centre, but I'm also aware that you have one of Europe's largest active surveillance programs as well. So I think, yes, I don't want listeners and viewers to be distracted by my overwhelming desire to have a super high volume centre like this back in Melbourne. But it is a very comprehensive prostate cancer program that you run here, everything from early detection, active surveillance up to more advanced disease. And the new building will be amazing. I'm sure it'll be a fantastic environment for everybody.
Yeah.
Great. So thank you, Markus, again for welcoming me back. I look forward to coming back then next year to look at the new building. Thanks very much.
I thank you very much, and you're always welcome here.
Thank you.
Thanks.
There are 5 operating rooms here in the Martini Clinic building, each of them dedicated to doing radical prostatectomy. There is only one operation that happens in all of these operating theatres every day of the week, morning and afternoon. That's radical prostatectomy, radical prostatectomy, radical prostatectomy, radical prostatectomy. So for example, here on Monday today, there are 10 radical prostatectomies happening. And sometimes they do 12 or 15 cases in a day. And it's still a mixture of open and robotic surgery. For this institute, of course, is very famous for being pioneers of high volume open surgery. At the moment, they have 4 Da Vinci robot systems here. And also, interestingly, I noted a couple of Hugo carts sitting here waiting to be used. But they still do upwards of 40% of their cases using open surgical techniques. Welcome here to Theatre 3 at the Martini Clinic. I'm in the operating room of Dr. Alexander Haese. We're doing our second robotic-assisted radical prostatectomy of the day. This is a young patient with unfavorable intermediate risk prostate cancer who's having bilateral nerve sparing using the Neurosafe technique pioneered by the team here at the Martini Clinic. So we'll show you the Neurosafe technique in action and have a little chat about that later in the podcast.
Off we go. So, and again, we see, always 3 instruments in from the very beginning. Needle driver on the lateral port on the left, and scissors and Maryland. 2 ports left, 1 on the right. And then we just go ahead and do the transperitoneal approach. Bringing the sigmoid to get decent views. Das ist gut. Druck mal auf 5 bitte. Mal schauen, ob es geht.
Ja.
Dankeschön. Let me see what we can mobilize from here.
Another technical point I noticed in Alex's theatre today is he runs his pneumoperitoneum at only 5 millimeters of mercury, just using regular insufflation, not air seal. And it's amazing to me to see how adequate the field can be by just using 5 millimeters of mercury.
So we reduce to 5 again. Yeah, now there's not much we need to do. Okay, so next step, ladder down.
So Alex has now finished his nerve sparing and he's just about to complete the apical dissection, meaning the prostate will be free. So the next step in the Neurosafe frozen section process is to undock at the center arm of the robot through the Alexis port and retrieve that specimen so they can prepare it for frozen section analysis.
So now this is the prostate here.
Beautiful looking capsule, yeah.
Capsule is nice. Here there's a small defect on the left.
Yeah.
That one we saw. Yes, some nodules, but not too much. Some, you know, it's if you eyeball, what could you say?
Yeah, perfect.
Yeah. Yeah, they would get markiert. And this is the right hand side. And then
Oh, you can clearly see the nodule, no?
yeah. So let's keep it clean. And all the usual inking. Apex is red. Anteriorly is black, just for the pathologist to be able to identify. And of course anterior here. Now yellow for the artificial margin. You just make sure that you can see well what I'm, so I just adjust myself to your camera. So let's give that small.
rechts.
Yeah. So this is the small defect that we had on the left, which we found. The green is obviously right. Goes into the container. Yeah. Okay. Blue is left.
Und Lichtstreifen links.
Now the rest will be inked. In the meantime, we swap the instruments. Have the stitch for the EVC ready. So
And how long does it take to get the frozen section?
it can take anywhere. If you are the first one,
Yeah, it depends
you
on
can
the queue.
be. It means a lot. If I would be happy if we were at 40 to 45
Yeah,
minutes.
yeah.
We have been waiting for 60 or 70 minutes. Sometimes they've all come at about the same time. So that thing is going to dry, and that's it.
Professor Haese,
Yes, sir.
wir werden als erstes 400 Fluid.
400 Cool, bitte.
Ja.
And thankfully, the frozen section came back all clear on this case. So hopefully our patient will get the benefit of full nerve sparing. Thanks so much to Alexander Haese for allowing me to observe these two beautiful cases at the Martini Clinic today. Day 2 here at the Martini Clinic. I'm in OR2 with Dr. Markus Graefen and team. Markus is doing a beautiful bilateral nerve-sparing radical prostatectomy on really a very challenging prostate, over 100 cc, very large median lobe. But again, using the very well described Martini Clinic approach, he is giving me a total masterclass in how to do bilateral nerve-sparing surgery. course, as ever, all 5 operating rooms are running here on Tuesday morning. Radical prostatectomies in all the operating rooms. They're planning to do 10 radical prostatectomies today, and also 2 salvage pelvic lymph node dissections using radio-guided surgery. That's coming up later in the podcast, something I'm really looking forward to. One of the most contentious areas in prostate cancer remains the role of pelvic lymph node dissection in patients undergoing radical prostatectomy. We've talked about that many times in the past on GUcast. But there's an interesting trial underway here at Martini Clinic involving lymph node dissection that I want to speak to Markus about. So Markus, this patient is participating in a randomized trial about lymph node dissection, I understand.
Right. So we all know that there's a really need for data looking at the role of lymph node dissection, and we have a couple of trials, mainly retrospective. We have small randomized trials with, I think, some which ask more questions than they answer. So we decided to look at intermediate risk patients on the role of lymph node dissection, and we do not compare extended versus limited lymph node dissection, but we compare extended versus no lymph node dissection. I think that gives us a clearer answer in this area. We certainly do an extended lymph node dissection high-risk patients. I think that's important for staging issues. But in this group, we're not really sure. So what we did is we call it the PREDICT trial, and it's including patients with favorable and unfavorable intermediate risk. And as I said, it randomizes them into either an extended lymph node dissection, and we say that it should be at least 10 lymph nodes. You might argue with that, but if you typically the average is about 20 lymph nodes that we're taking on, and the primary endpoint, just to make it an endpoint that we can see during our professional life, is PSA recurrence. Though it's not the most important, but it's one of the first signals, I would say. So it's 3 years, and it's a non-inferiority trial. Non-inferiority, we want to show that leaving the lymph nodes inside does not make a difference in biochemical recurrence. Certainly the secondary endpoints are cancer-specific survival at 10 years, so we have already the improvement from the ethical committee for these endpoints. But as I said, to make sure that we see an early signal, we use biochemical recurrence as the first endpoint. We certainly will look at complications. I will as well look at the role of patient management. I think that's very important. Does it make a difference when you know about the lymph node status, about management with respect to, is there maybe more imaging? What about the complications? That's another very important endpoint as well. And that's what we're doing.
Very nice. So that's a big study. That'll be.
Yeah, it is a big study. We discussed with our statistician, and he finally, due to the fact that we do a pre-specification of favorable and unfavorable risk, and due to the design of the trial, doing as a non-inferiority trial, we actually need more than 3,000 patients for that, which is a really big number of patients. But on the other hand, I think we all know that the differences are not that big, that we really need a lot of patients to characterize those who benefit or not benefit from a lymph node dissection. We certainly include various other stratifications, like, for example, the usage of MRI in the biopsy, the diagnostic biopsy. We use the mammograms, the traditional one, the Briganti without the MRI, apply that to that. We use NSKCC mammograms for that. So we would like to kind of really fully answer that question. Therefore, we need some time, but we have already recruited over 1,000 patients here. We've now opened the study with an electronic case report form available via the internet to other centers. We are now discussing the situation with Karolinska and with Copenhagen. We're usually very good recruiters in randomized trials. So we hope that we can expand this to an international group because we need so many patients, and if someone wants to participate, we are more than happy to have more centers in the study.
So the prostate has now been freed. We're undocking the center arm and going to retrieve the prostate through the Alexis port so we can do the frozen section. So big prostate, Markus.
It is indeed a big prostate. There's a huge median lobe and a bit asymmetric, as you see. The capsule is very clear. The apex is clear. So we do the frozen section. There's nothing on palpation, which we expected actually. So I try to, like, this is the area where we dissected the neurovascular bundle or separated the neurovascular bundle, to say better. So the whole area here. And you see this is the peripheral zone, this is the anterior part. Now we go to the right side. The inner part we paint yellow, just for orientation for the pathologist. And we know the data from our center and from other centers who have adopted this technique that the small, the focal, Gleason 3 to 4, 1 millimeter positive margins have no prognostic impact on one hand, and if you dissect the tissue, the corresponding tissue, we typically won't find tumor, and therefore we make a special marking where we have just 1 millimeter positive margin with a Gleason 3. We try to identify the corresponding adenovase fascia there, and therefore the pathologist needs to know and tells us where's the anterior side, which is the black line, whereas the red is the apex, so they can pretty much tell us it's like the 4 slice, for example, away from the black line was here, in the mid area or close to the black line. So we have a pretty good orientation when they have focal positive margins where that spot is and where we should dissect the tissue. So the outside on the left is blue, that's the way we do it. The right side is green. Even though it looks pretty much the same here, under the microscope you can clearly identify the colors very nicely, distinguish between the green and the blue one. So we have the patient's name here and the side. Typically check that. That's the left side. Okay, perfect. Paint the rest of the prostate.
Classic looking huge BPH nodule. We don't often get to see that. We don't section these ourselves, but for students you can see a classic zonal anatomy of the prostate. And this patient had a lot of lower urinary tract symptoms, I think Markus did.
Yeah, that was one of the reasons, like when we discussed the indication for surgery, he had several biopsies, like full biopsies with Gleason 3 and a PSA of 11. We were discussing back and forth, active surveillance certainly with him, but he opted because he was so much, let's say, impacted his quality of life by his obstructive symptoms, which you can imagine with this median lobe and the size of the prostate. And when he came here, the PSA was already risen to 17. So I think it was a good decision. He's a young chap.
So if there are usually 10 or so radical prostatectomies going on every day here at the Martini Clinic, what proportion are having frozen section Neurosafe, Markus?
I mean, like if we do a nerve sparing procedure, we always that's like a rule that we do a Neurosafe.
Yeah.
And so I would say 95% at least, because we do in high-risk disease, for example, if there's the disease only on one side, we try to spare the nerves on the other side, and as we have shown and others that it makes sense. It's not that all these patients need adjuvant treatment afterwards, and we saw as well, I mean, we have all these data saying that locally advanced or high-risk disease, that a third of the patients or a fourth of the patients in the final pathology end up as bone confined disease, where you can easily spare the nerve. So we have the, I may say, the luxurious situation that we can kind of push the border a little bit because we get this feedback directly during the case. So if it is positive, yeah, then we resect something more. And we've shown as well in a big study that if you have a positive margin during the surgery and you resect the tissue, that you don't compromise the outcome of the patient. So,
Yeah, you've reported that the biochemical recurrence is the same. So
yeah, I mean, we were kind of scared certainly that we might do some tumor spilling or something like that, but that has not been shown. So I think it's very safe, and I would say like precision type of surgery that you do, orientating on the individual location and size of the disease. So yeah, I like it, I have to say.
fantastic.
So yeah, I think we completely preserve the nerves by the shape of the prostate. You can see the Randomized fashion here. It's very into that, staying on this side, and then it's fascia on the directional fat, and you can see the directional fat here. And the other important issue that I always like to do is like these are the ligaments. We don't cut them, we don't destroy them, we just leave the anatomy around here intact.
So Markus, while we're waiting for the frozen section, I couldn't help but notice in the other corner of the operating room there's another robot. There's the Hugo system, which is just beginning to roll out around the world. And so you have about 4 Da Vincis, and now this Hugo is getting ready to go. So as an expert in robotic surgery as well as open surgery, what are your comments on the future of these technologies?
Yeah, I must say I'm very happy that we have something like a competitor in this area, and I think it's usually fruitful if various groups are working on the same subject and trying to develop the field. So I really embrace that there's a new technique. Certainly the costs are something we hope that will be reduced as well when the competitor is there. We've tried it out. It's a real alternative, I may say. We did all the trainings and all the work that you need to apply the robot at the Orsi Institute, which was very nice and very well organized. And we're actually waiting to start the first cases. There are some issues about sterilization in Germany. The rules are so strict and it has to be fulfilled like it is in Germany, but we are waiting, I would say, every day until we get the allowance to use the system, and we are very keen to do that.
And I suppose, as you say, having a serious competitor in the market will hopefully drive costs down and maybe make robotic surgery more accessible to people who at the moment don't have the option just because it's going to be a few €1,000 extra or their insurance doesn't cover it and so on.
That's the hope that we have. And I say the console, if you try it out at the console, is very simple for the surgeon because it's all the instruments, the foot pedals and so forth are exactly like at the Da Vinci. It's like if you go to a different car, you still have the brake and the gas on the same side. You have the steering wheel, and it's pretty much the same like with the console. It's a bit more, I would say difficult, but it's certainly different for the guys on the bedside surgeons and the nurses, because it's not one card with all the arms, but with 4 cards, and you have to think about a little bit about the positioning. But once you've done that, it's a really good system. And as I said, we are curious to try it out. It's working with 3D glasses. It's not like the console that we have where we look inside the camera, but it's a 3D glass with a screen. It's kind of an open console. If that makes a difference with the communication with the team, one can experience on his own. But we're happy to start.
So by and large, if you are an experienced Da Vinci surgeon, many of our listeners are already well-established urology robotic surgeons, and one of these machines arrives in your hospital, the transition from experienced Da Vinci over to becoming competent on this hopefully will be relatively short.
Absolutely. I think it will. It's like driving with your VW to work or driving with your Opel to work. You just take a car and go. And it's anatomy and all that stuff is the same. Instruments are pretty much the same.
Ja, wunderbar.
Super. Dankeschön. Jo, ciao. We expected that? No, we don't. So it's negative margin. It was at least 3 in the biopsy, and finally we ended up with no surgical positive margin, and so we can leave the nerves aside. I think the nerve span was really good, and yeah, I'm very happy. I can tell the patient up front, like when he wakes up, I can say, and I will call his wife now, and I think she will be happy as well.
Wunderbar. I know what that means.
Okay, genau.
That's all we have time for in part 1 of our visit to the Martini Clinic. Thanks very much to Markus Graefen and Alexander Haese for allowing us to spend time in their operating room today. Join us again for part 2 when we will chat with Dr. Derya Tilke about research here at the Martini Clinic, and I get to scrub into a PSMA radio-guided surgery case with Dr. Tobias Maurer and discuss where to next for this exciting intervention.